Hello guys, so welcome back to the part 2 of the A to E assessment. So the part 1 we started and then we ended at a point. So the part 2 is just going to be a continuation of where we ended. It's actually a long video, but I hope you would have time to watch it and then be able to understand what it is. In the meantime, if you have anything or any question to ask, kindly drop it in the comment section and I'll make sure I answer you, or I make another video tackling it. Now we go to C is circulation. So circulation, we're checking for perfusion, we are checking that patient's blood pressure is okay, patient's heart rate is okay under circulation. But we were supposed to do capillary refill under circulation, but because you did it for checking the oxygen saturation, you tell the assessor, I was supposed to do capillary refill during the circulation, however I've done it when I was doing the breathing, the B, and so I'm not going to repeat it again. So now what I'm going to do is I'm going to check your pulse rate and I'm going to check your blood pressure. So with your pulse rate, I'm going to check your wrist, and then I'm going to count your heartbeat, and then with the BP I'm going to connect a BP cuff. Is that okay? So that's fine. Okay, which hand would you want me to use? It could be that the patient, so we do have patient that's had surgery on one hand, or patient that have cancer, different things that they are not allowed to do anything with one hand but they can do on the other hand. So it's just fair to ask the patient first before you go ahead. All these things are very important. So you ask, which hand would you be comfortable for me to use? So okay, you can use the left hand. That's fine, thank you. So you just sanitize your hand again and you say, okay, can I confirm, have you had any surgery on that arm? Are you in pain? Can I check there are no rashes, anything, so I can confirm that this hand is safe to use? So I'm going to check your pulse rate, but I'll need to touch your wrist. Is it okay for me to touch your wrist? Patient says it's okay. So now you try and palpate or locate the radial artery. Now the radial artery is always on the side where the thumb is. So you put just 2 fingers on there and then you press it against the bone and you can feel the patient's artery. The moment you feel the radial artery, you let the examiner know that I have located the radial artery and I can feel the radial pulse, and I am going to start checking my patient's heart rate and the time for 60 seconds, and the time starts now. So the assessor would assume the time with you so they can confirm, as I said in the respiration, that it is 60 seconds. So you can start. So whilst you're checking it, you should note how it is, if it is the characteristics of the pulse, if it is faint, if it is full and bounding, if it is irregular, anything. That is what we are looking for. So after you get that, you can say, okay, so the patient pulse was 92 and the characteristics was that it was full and bounding and regular. You have to say all these things for the assessor to hear you say it. And don't worry about the patient. If it's the patient, then talk to the patient. If it's, so you can even tell the patient, so it's 98, it's full and bounding, and it's very okay. You tell the assessor. So whatever you're saying, the assessor is also listening to it. If it's irregular, the pulse is so the pulse is not regular, this and that. Is it your normal? Some patients even have atrial fibrillation and they know that their pulse will not be regular. But in all this, just be communicating with the assessor and the patient. So after you have done, sanitize your hand. You can document, ask permission, document, sanitize your hand. And then now we come to the blood pressure. So with the blood pressure, you look at the patient's arm, on the same arm, and then you check the cuff that you need to use. The patient has a bigger arm, you use the bigger cuff. If the patient has a smaller arm, use the smaller cuff. So before you do that, now some important things to note is we have to note the things that we need to be using. The brachial artery. So we need to check the brachial artery. So the brachial artery is always at the inward part. The arm, the inward part towards the patient, around this area. That's where you find the brachial artery. So you can palpate for the brachial artery to find it around the antecubital fossa. And then always make sure the blood pressure cuff is about 2 to 3 centimeters away from the antecubital fossa. So if this is the antecubital fossa here, that's the back of the elbow, the cuff should be about 2 to 3 centimeters away. You should be able to palpate for the brachial artery. It's always inward towards the patient. And then after checking that, the BP cap, so there is a picture there, always has an index marker on an artery liner. What you do is that artery liner has to line with the brachial artery where you felt it. So you tell the assessor, so I'm going to be palpating for the brachial artery. Now I have located the brachial artery. I am happy to continue. So you say all these things. Now the cuff is within size of the patient's arm. So I'm going to place it 2 to 3 centimeters above the antecubital fossa, and I'll make sure that my artery liner is my artery marker is in line with the brachial artery. Now after putting it on the patient's hand, I am going to check that it is not too tight or too loose by slipping 2 fingers into. Now when you are slipping 2 fingers, you should go this way and not that way, because we assume that if you're going that way, your fingernails may actually scratch the patient's skin. So you go in this way to check that, okay, it is 2 fingers can fit in, and then it is not too tight or too loose. So after you've put that, you explain to the patient that you are going to inflate the cuff and that it might be a bit tighter. They should bear with you and that you finish very soon. Make sure the patient's legs are not crossed, because they can affect that. Make sure that the patient is not talking. Make sure the patient is comfortable and quiet, and you can now press to check. Meanwhile, you have already taken the SpO2 machine off because you've done your breathing already, you've done your pulse with your hand. So you just wait, and then when that also reads, it reads faster actually, you ask the patient, always remember, is this your normal? Patient might be hypotensive, patient might be hypertensive, so you don't end up drawing conclusion, hey, my patient is dying 80/60, I need to. No, it might be the patient's normal. So you ask, can you confirm if this is your normal? They know, so they will tell you, yes, that is my normal. Normally that is what I get. Then you know that, okay, you are doing well. If not, always refer, because your question paper might tell you that patient came in hypotensive and all that, so you know what to use for your care plan. So you can ask permission and document that as well. Then from the circulation, we've done all that. Then you check if there are any bruises, any shift of fluid from the patient. So if you check there are no bruises of fluid for the patient, you can confirm that circulation wise patient, you've checked that and patient is okay. Now we go to disability. So disability, we are taking into consideration every other thing. So check if the patient is in pain. So you can ask, are you in any pain? If the patient say, I'm in pain, oh, pain, okay. And you don't just skip it. Show the patient. As I said, be intentional about your patient. Are you in any pain? Yes, I have a headache. So don't just say patient has a headache and then you write. Ask the patient to point to where the pain is, because somebody might say I have elbow pain, and then you ask them to point and they'll point here. So it is very, very important. So are you in any pain? Yes. Can you tell me where the pain is? Oh, I have a headache. Can you point to it for me? And the patient points here. Oh, I'm so sorry. Be compassionate. I am very sorry about that. So on a scale of 0 to 10, with 0 being no pain and 10 being the highest, can you rate your pain for me? Patient might say 6/10 or 7. That is another thing you can use for your care plan. Patient is in pain. So patient says it's 6/10. Note that. Is there anything you do to relieve the pain when you lie down? Is there any other thing you do to relieve the pain aside medication? Patient may say, okay, maybe sometimes I take paracetamol, but sometimes when I lie down, it's better. Oh, do you want to lie down now? So right now, do you want to lie down now? Patient might say, no, it's okay. Patient might say, yes, I want to lie down. So all these things, they'll be looking to see that, yes, you are actually adding compassion, you are adding every other thing. So do you want to lie down now? No. Do you want to sit up? So depending on what the patient says, you go on to ask, just to know that you are making the patient comfortable. So if the patient says, no, that's okay, the pain, okay, sorry, so I am going to escalate this to see if I can get some pain medication for you. Is that okay? Or you could just say, okay, according to what I know, you had paracetamol about 2 minutes ago, so it will kick in. Or you had paracetamol about an hour ago, so we wouldn't be able to give you paracetamol, but I will escalate to see if there is any other thing we can do for you. Is that okay? All right, so moving on, So now you have reassured the patient. He knows that you have acknowledged the pain and there is something you are going to do. So moving on, you can ask, okay, so have you urinated in the last 4 hours? Because we check to see that patient has to be able to urinate every 4 hours. You're checking against AKI, acute kidney injury, or you're checking against the fact that patient is dehydrated or not dehydrated. Patient is having fluid volume excess. Patient is having fluid volume deficit. You know all those things. So you ask, have you had any urine? Have you urinated in the last 4 hours? Patient says yes. Okay, when you urinated, what was the volume? Was it a lot? Patient cannot tell you the exact amount, but you say, was it a lot or it was scanty? Patient will tell you, oh, it was normal, the normal urine. Okay, can you tell me, did it have a foul smell? Was it clear? Was it concentrated? So you're using all these signs, so you could actually bring up a problem from it, maybe dehydration or anything. Patient said, no, it was okay and everything. Oh, that's lovely. Then you can ask the patient as well, because you need to know the patient's blood sugar. So as well, it's called BM, so blood glucose. But because you are not supposed to check and the patient does not know, you ask the assessor, can you please confirm the patient's blood glucose for me? So the assessor might say it's 3.4. So it's very important for you to know the range of the blood glucose. I think I'll put it up there for you to see. So when the assessor says it, you can tell the assessor, I can confirm that the patient's blood glucose is within the normal range and there is no concern. It might be that it is low, so I can confirm that the patient's blood glucose is low. I'll need to escalate this. So you write it down as well. Patient might be having hypoglycemia or hyperglycemia. That is also another thing to be mindful of. So you ask about that, and then after seeing all those things, you go on to disability. So that's the disability. So you're checking for the pain. You're checking for urine if the patient has urinated and if it's okay, dehydration and all that. And you're also checking for patient blood glucose, because you are not allowed to check the blood glucose. It's another station on its own. It's another tax on its own. You just confirm from the assessor. And then under disability too, you have to check the patient's level of consciousness. By doing that, you have to check if patient is alert. So you've been talking to the patient all this while. So of course, patient is alert. Now you ask the patient their orientation to time, place, and person. So can you confirm for me where you are? Your full name. Patient tells you that they are alert. Can you tell me where you are? Oh, I'm in the hospital. Okay, that's lovely. Can you confirm the date, today's date for me, and the year? The patient will confirm the date. Can you confirm who I am? Not my name, but what do you think I do? Okay, you're a nurse or something. Do you know where you are? So if the patient gets any of this wrong, you know that patient is confused. So that is also another thing to put down, confusion. So you say, can you tell me where you are? Oh, I'm in my house whilst the patient is in the hospital. You correct the patient, no, you are not in the house, you're actually in the hospital. But you put it down because patient was confused. So when you ask these questions and patient fails to answer them or answers them wrongly, it gives you an idea that patient is also confused as well. So as you're doing the assessment, it helps you to be able to get your problems for the planning. So with the disability done, we now go to exposure. So exposure has to do with temperature and checking that the patient's, from the part that is visible to you, the patient body is okay. So with the temperature, you tell the patient that, okay, I'm going to point this thing to your forehead, the thermometer to your forehead is going to check your temperature. If you hear a beep, do not be scared. It is just me checking your temperature. Now check that the patient's forehead is not sweaty, doesn't have any dust, it's not sweaty, no balls or bumps or anything, and then the room is not too warm or cold to affect the temperature. So you tell the assessor, I can confirm that the room is not too hot or too cold to affect the patient's temperature. Also, I can confirm that the patient's forehead doesn't have any sweat, doesn't have any bumps, and I can go ahead and check. So you've already told the patient what to expect, that the beep is the thermometer. So you hold it a few centimeters away from the patient's forehead, press on it, wait a while, beep, and then you get the temperature. Say, okay, assessor, my patient temperature is 36.4, and I can confirm that it's the normal body, within the normal range of the body temperature, and then you write it down. It could be that patient is hypothermic. So all these things actually help. Then you say, assessor, from the part visible to me, I can see that the patient doesn't have any indwelling equipment or any indwelling apparatus. The patient doesn't have any cannula, the patient doesn't have any catheter, the patient doesn't have any boil, the patient doesn't have any bruise, the patient doesn't have any injury, the patient doesn't have any object in place as I am seeing. Can you confirm the parts that are not visible to me? If the patient has any indwelling, and the assessor will say no, that means that your patient is okay, doesn't have any bruise, doesn't have anything, and the part visible to you is fine. Assessor has confirmed that the part that is not visible to you, you are not going to turn the patient to anything. Just say to the part visible to me, this is what I see. Can you confirm that the part that is not visible to me is also good and does not have any indwelling thing or anything like that, and the assessor will confirm for you. Mind you, so under circulation, when you are checking the blood pressure, check for the arm that you are using to see that there is no cannula or indwelling objects, maybe pick, incision, or no pick line or CVC or anything. Just check that the arm is okay and nothing is going to reflect on it. So now we've done our A to E assessment and we are okay. So now we can plot on the news, and then with our score we will know whether to escalate, or we will know when next we would have to check maybe. So you tell the assessor, so after doing this I got a new score of 1, which is okay, and it was because patient's respiration was high, but patient claims that it is the normal for her and there is no need for escalation. So with this I can confirm that I would have to check the patient's OBS or the patient's vital signs every 4 hours. It's at the back, so you would know the hourly rate to check it based on the new score that you get. So when you say this to the assessor, that is fine. You need to verbalize it to the assessor and you need to tell the patient, so your news is 1 because your respiration was high, which you have said is normal. So that means that you are very okay, and apart from the certain things that I saw, apart from everything was fine from head to toe. So I am happy. You might not need any escalation except for the pain that you complained about, and I'm going to escalate and all that. So to be able to get more problems for your planning, you can go ahead and ask the patient, okay, so can you confirm why you are in hospital? What brought you to the hospital? The patient might say, oh, because I'm dizzy. Okay, so when did you start feeling dizzy? How many days ago? Have you taken any medication for the dizziness? Are you taking any medication? So does it stop you from doing any other thing? Like when you are dizzy, does it stop you from walking? Does it stop you from standing? Oh yes, when I'm dizzy I come back. So you know activities of daily living now is compromised because of that. So you're able to get problems, dizziness, you're able to get like patients activity of daily living is compromised because of that, patient mobility is compromised because of that. So you are able to come up with plans. So remember everything that you saw or every problem that you acknowledge. Remember our patient said she was in pain 6/10. That's also 1. Remember, maybe our patient was a bit confused and couldn't answer where they were and said they were in the house whilst they were in the hospital. So that's confusion. So now we have about 4 different care plans that we can look out for. So when you are done, you just thank your patient. Thank you very much. I'm going to make a plan with this. I'll come back to attend to you. In the meantime, do you want me to do anything for you? No. Are you sure? She says yes. Are you comfortable? Yes. Do you want me to help you on the bed? Depending on where they were. Do you want me to help you on the bed? Do you want me to help you with anything? Patient says no. You said okay. So I'm going to leave you. Remember to press the call bell if you need anything, and one of us, the nurses, will come to attend to you. Is that okay? Thank you. Then you go and then verbalize. Don't do it. Tell the assessor that, so I'm going to pack my equipment back to the equipment library or back to the equipment room. I'll make sure that I clean it with Cleaner wipes, make it ready for use for another person or for my colleagues, and then I'll perform a full hand wash. So you say, I'll perform a full hand wash according to WHO standard. Discard the paper in the general waste. Make sure my equipment is clean. And then document anything that I have done for the patient. Make sure that my documentation is accurate. And then you are done. So this is how it's supposed to be. I know it's a lot of talk, but actually this is just an index for you to understand what the A to E assessment and the news chart is and what you are doing. So I'll do another video on how to plot on the news 2 chart as well, so you understand what it is. But this is what to do when you have been asked to do a physiological assessment or an A to E assessment using the news 2 chart for a patient. This is what you're supposed to do. So I'll do a practical video making sure that I stay within the 20-minute time limit that's normally given in OSCE for you to know how fast you're supposed to talk or how slow you're supposed to talk, what to do, what to say, what to verbalize. But I believe that this has been helpful and we've been able to know the rationale behind a lot of things. Thank you for watching this. As usual, like, share, subscribe, and follow for more. And I'll see you on our next episode. Bye.